the society has worked tirelessly to try to get these surgeons together, and I think we've succeeded to quite an extent because this is not the only event that we've had. We've had events in the past, and I think the SIN chapter is a very good example of us getting together. When we talk about cardiac surgery and the competing interests with cardiology, I think what we need to understand is that there are 4 stakeholders. The stakeholders are the patient, the interventional cardiologist, the cardiac surgeon, and industry. Okay, and each one has its own interest. The patient wants a small incision. The patient wants pain-free incision. The patient wants an outcome that is good, and that was alluded to briefly by Dr. Tariq Farman. We cannot continue to scare our patients. However, the informed consent makes us, we want to tell the patient what the complications are. And that's why I talked about this, that risk identification and risk mitigation is part of the informed consent process. There are 2 things that I need to talk about. One is the changing landscape of cardiac surgery. This has been talked about by Taimur a lot, and I think he may have taken it out of my vocabulary. You cannot teach old dogs new tricks. I'm definitely into that category, but there are young surgeons over here who will now take up the mantle and take this forward. So I think that's an important thing. What does the college think about it? So with the way we are changing, the last curriculum, when Anjum Jalal asked me to put it in, I have put it in catheter-based skills, because quite clearly that is the way to go. Patients do not want big operations, big incisions. It's got to be minimally invasive, and perhaps even better to have a catheter-based skill, catheter-based stuff done. And as you may or may not know, in Germany, most of the TAVRs are done by cardiac surgeons. So why can that not happen over here? So the way forward, as far as I think, is to either have, as been mentioned before, comprehensive valve centers, comprehensive aortic surgery centers, where you can teach these skills to our new surgeons, or depend on simulation. Simulation is perhaps the other way out to help you with the catheter-based skills. If people have seen the virtual cath lab, you can do angiography, you can do an angioplasty, you can do a TAVR, you can do everything over there. And once you're armed with that skill, you can then take it forward, get proctored, and start doing it. Because if you really look at it, maximally invasive is going to go away for the most part. Minimally invasive, plus minus, like it was mentioned before, catheter-based or robotics. I think that's the way it's going to be, like it or not. Artificial intelligence is going to be a key part of risk identification, mitigation, and perhaps may even run that robot for you. So we may all become redundant as time goes by. So the bottom line seems to be that we need to change. Darwin's theory has been proven wrong. It is not the survival of the fittest. It is the species that is most willing to change is the one that will survive. So if we do not change, the change is going to be driven by, like I said, the interventional cardiologist, by the patients themselves, and by industry. It is a multi-billion-dollar industry out there for stenting, and they will continue to push for stenting. If you look at the partner trials, the Sapiens, the Baxter did not even share the data with people. Talking about data, that's the next thing I needed to talk about. We need to be very introspective about what we do and what our long-term results are. We cannot continue to depend on what the West says. We need to have our own data. And hopefully at the biennial meeting, we will launch, we've been talking about this for a long time, but we have a red cap based database that we've tried. We give it to all participating centers, and you put in your own data for demographics, for outcomes, because data drives performance. Data will tell you where the gap is, and you can go back, work on it, and try to improve your results. Thank you very much.